clinical perspective, but from clinical perspective, can you see my slides? So from clinical perspective, age, BMI, and if you measure C-peptide or insulin level. So if there is a genetic background, yes, there is. And actually, if you do genetic testing, you can identify this cluster very easy. So in type on the SID, which is severe autoimmune diabetes, you will find HLA typing DQ and DR3 and 4 in that scenario. In severe insulin deficiency diabetes, there is a polymorphism in a gene on chromosome number 10. It's called transcription factor 7, like 2. And actually, this is a gene that code for pro-glucagon and GLP-1. In severe insulin-resistant diabetes, there is another gene called adiponutrin protein, which is actually related mostly to intrahepatic fat. And that's why this group end up with fatty liver and also chronic kidney disease. Mild is not genetic, it is a strong heritability. And as I mentioned, aging is degenerative disease. So this is not a genotype cluster. So if I classify those people, what complication that those people develop? SID develop usually microvascular complication. And this is a major problem in them: diabetic neuropathy, nephropathy, and retinopathy. And we know that people with type 1 diabetes now and slowly progressive type 1 diabetes develop usually microvascular disease. Severe insulin deficiency diabetes develop only two complications very common: retinopathy and neuropathy. They don't develop chronic kidney disease, but retinopathy and neuropathy, and also cardiovascular disease. Severe insulin deficiency diabetes, they develop chronic kidney disease. Very early, they develop chronic kidney disease. They also develop non-alcoholic fatty liver disease and hepatic steatosis, and also cardiovascular disease. So this is a severe form, but usually they develop those early. They don't develop retinopathy or neuropathy. That will be, very strange scenario. Mild obesity diabetes usually don't develop that much complication. And if they develop, it may be cardiovascular disease. It's similar to, any person who have also dyslipidemia or smoking or hypertension. Maybe they develop, but usually they don't develop any of the microvascular complications. And mild age-related diabetes mostly develop cardiovascular disease, but they don't also develop other microvascular disease. So putting people with diabetes in just one basket and think that they are all the same is absolutely wrong. And people develop different complications and different problems. So let me, help you in identify those people and also understand how we manage each one. So severe autoimmune diabetes, which used to be called type 1 diabetes or latent autoimmune diabetes, they are usually diagnosed in young age. So lower than age 30, but sometimes they develop the same problem at age 50 and above. So you can see in young age and also in old age. They are always lean people. They are not obese, BMI lower than 25. And if you measure antibodies, anti-GAD65 antibodies, you will find them positive. And they have very low C-peptide or sometimes undetectable C-peptide. In some patients, there is actually detectable C-peptide, so they have beta cell reserve. That's why they develop diabetes in age 50, not in very young age, because they still have beta cell dysfunction. As I mentioned, there is genotype DR3, DR4, DQ8 of HLA, and there is many other autoimmune diseases. They may have thyroid disease, vitiligo, pernicious anemia, celiac disease. And interestingly now, we know that you can prevent this for up to 2 to 3 years by a new drug called teplizumab, available now in the US for IV infusion for 14 weeks, I'm sorry, not 2 weeks. But it prevented diabetes, this type of diabetes, for 2 to 3 years. As I mentioned, they develop microvascular complications. And their treatment is insulin. Multiple daily injection or insulin infusion pump. But if they are with beta cell reserve, you may give them long-acting insulin and sulfonylurea, or even glenize or DPP4 inhibitor at the beginning. And they can be on this medication for quite some times before they will be in multiple daily injection. So there's a first appearance here of sulfonylurea used in this particular population. If you look, so you have to remember, this could be C-peptide undetectable or detectable, and the treatment is insulin or long-acting insulin and sulfonylureas. What about the other group? The other group is similar exactly to that group, but if you tested their antibodies, it is negative. And they are not in younger age group. It is in age 50 and above. They are lean population as well. Antibodies are negative. C-peptide is low, but not significantly low. It will be still above 0.3. And their A1C at diagnosis is usually high. You will see it 9, 10, 11. And it's very progressive disease, and you cannot prevent it. So they're different than the other one, the autoimmune, you can prevent by monoclonal antibodies, but this one you cannot prevent it, and it's progressive, and usually have a very poor control. As I mentioned, they develop retinopathy and neuropathy. At the beginning of the disease, maybe the 23% have retinopathy, and retinopathy gets worse if the A1C is high, and they get neuropathy, and rarely it recover or disappear. Treatment of this group is basically sulfonylurea. So you give them sulfonylurea or glenize to stimulate their beta cells. And later on, you give them long-acting and sulfonylurea, and then finally insulin. So as you can see here, there is no room for GLP-1 receptor agonist or metformin or SGLT2 inhibitor, all what you need, because they have beta cell problem, to stimulate beta cell by sulfonylurea. If not, you add long-acting insulin and then later insulin. So again, progressive, unpreventable, poor control, and the treatment is sulfonylurea and insulin or just insulin. Again, this is around 18% of people with diabetes. So those are now 6 and 18, 24% of people with diabetes are not treated by any of those medications that we just mentioned, as GLP-1 and SGLT2 inhibitors. And the major treatment is insulin and sulfonylureas. What about severe insulin-resistant diabetes? This is the third severe form of diabetes. Again, usually occur above age 50. Their BMI is usually high. Those are obese population. And if you measure their C-peptide, it can be normal or it can be high. And there are severe insulin resistance at level of adipose tissue, liver, and muscles. And this is a preventable type of diabetes. Diabetes prevention program showed that if people have severe insulin resistance and they lose weight, they get very good results. But usually this group has a very poor control. And they develop very early chronic kidney disease and fatty liver disease. And as I told you, the gene encode for accumulation of fat in the liver. And even some people say, this is not a diabetes. This is a complication of liver insulin resistance due to accumulation of fat in the liver. The risk for end-stage renal disease is 5 times higher. And as I mentioned, from the beginning, NAFLD, non-alcoholic fatty liver disease, in 19% of them are diagnosed. What you need to do for this population, the most effective is weight reduction and low carb diet. You have to improve insulin sensitivity by metformin and by glitazone. You can give them any other medication. You can give them GLP-1, SGLT2 inhibitor, sulfonylureas, but even with all those medication, they are not responding very well. And ultimately, you will give them insulin, and most of the instances, very high dose of insulin. Those people sometimes require 100 units of insulin, 200 units of insulin, U500 insulin. They are extremely insulin resistant. So it is preventable, it's poor control. They need weight reduction. That's what will work for them. And insulin sensitizers, and even sulfonylureas and all other medication you may give them, but they are not working enough. But this is a group that you can give them GLP-1 and SGLT2 inhibitor. This group is 15% of people with diabetes. The mild obesity diabetes, I think every one of us is seeing always this population. They are at age 40 to 50. They're obese. They have high C-peptide, and they are insulin resistant, but not severe. It is only at the level of the adipose tissue. Again, you can prevent this type of diabetes. Once they lose weight, they get marked improvement. And as I told you, they do not develop complication. So weight reduction, metformin, GLP-1 receptor agonist, SGLT2 inhibitor are the right medication for this group. And this group is only 22% of people with diabetes. And they usually respond very well to weight reduction. And then the last group and the biggest group is mild age-related diabetes. People get older and they develop diabetes. So usually above age 60, their body mass index is not way high. They may be in normal weight or slightly overweight. Some few can be obese. And as I mentioned, those people are getting diabetes when they get older. So their pancreas is degenerative, is not secreting enough insulin. So you'll find C-peptide normal or low normal in that scenario. You can't prevent this disease, but you can easily treat this disease. You can get very good control quickly. And as I told you, they don't develop complications except cardiovascular. So what is the treatment? The treatment actually is sulfonylurea, a small dose of sulfonylurea, 1 milligram, 2 milligram of sulfonylurea, or if you are using glibenclamide, 2.5 milligram or 5 milligram, and they do very, very well. Or you can give them DPP-4 inhibitor, sitagliptin or linagliptin or similar. And metformin is only if they are overweight and obese, and GLP-1 if they are obese. But this group is 39% of all people with diabetes, and the main treatment is sulfonylurea. So sulfonylurea is for mild age-related diabetes. Sulfonylurea is for severe insulin deficiency diabetes. Sulfonylurea for some patients with severe autoimmune diabetes and also severe insulin-resistant diabetes. So in reality, if you look, sulfonylurea is if more used than any other medication in treatment of diabetes. Just a reminder, this is unpreventable, good control, and a small dose of sulfonylurea can be effective for this population. In different ethnic groups, like in China, they found that mild age-related diabetes is around 50%, followed by mild obesity diabetes and severe insulin-resistant diabetes. In India, and similar, you can see in Yemen and in many other places in this area and South Asia in general, and you will find that severe insulin deficiency diabetes is the most prominent. That's why you see people are not significantly obese, and they are not making enough insulin. They are not insulin resistant, and that group can develop microvascular complication, and you can treat them easily by sulfonylureas. And then mild obesity diabetes, which need more weight loss. So just to give you a summary, I mentioned genetically you can detect any one of the 3 severe form, easy, you can do it. Regarding age, the younger is the only severe autoimmune diabetes, and the older is major mild age-related diabetes. Those are older population. So if you have younger, you have older, the others around 40, 50 years of age. Regarding the body mass index, the insulin-deficient diabetes are usually with lower BMI, and the obesity diabetes and severe insulin-resistant diabetes are the obese population, as I mentioned. And then mild age-related diabetes, BMI is usually lower than 30. If you measure C-peptide, and insulin-deficient diabetes, C-peptide will be low. In obese population, you will see normal or high. And in old patients, it is usually lower normal. If you look to insulin resistance, I mentioned the severe insulin and mild obesity diabetes are the only two that are resistant to insulin. And the severe is the one which is highly resistant. Preventable, you cannot prevent in most of them. The only one that you can prevent is severe autoimmune diabetes now, and the obese ones you can also prevent. As I told you, the severe form has poor control. The mild form has good control, and complications are different. Microvascular complication in SID, retinopathy, neuropathy in severe insulin deficiency, chronic kidney disease and non-alcoholic fatty liver disease in severe insulin resistance, no complications in MOD, and no complication in MARD or cardiovascular disease. And again, the treatment is different. Here is you give them insulin or long-acting insulin and sulfonylurea. In severe insulin deficiency, you give sulfonylurea. This is the main and long-acting insulin. In severe insulin-resistant diabetes, they end up benefit from weight loss. But any other medication can be used, and they are extremely resistant, and they need large dose of insulin. And in mild obese diabetes, all what you need is weight reduction. You can give them GLP-1, SGLT2 inhibitor, or metformin. And in MARD, the best treatment is a small dose of sulfonylureas and DPP-4, and the other medication if they are obese. Now, it's telling us years from now, we are moving in the precision medicine, identify our patients and give them the right medication. So now, why sulfonylureas and why now? Okay, so let me first agree that metformin is the best initial treatment for people with diabetes. It's improve insulin sensitivity. It brings A1C quickly down by up to 2%, no hypoglycemia, no weight gain, very cheap medication, long-term safety, have some other additional benefit like cancer, and also to reduce cardiovascular outcomes. So there is no objection to the use of metformin in most of this population. So what about sulfonylurea? And why? So we know that the aim of most people with diabetes is to get a better glycemic control. And better glycemic control is related to the medication. So some medications are very potent. Metformin and sulfonylureas, for example, drop A1C from 1 to 2%. All other medication drop A1C, but not as much as what you can get from metformin and sulfonylurea. So from efficacy point of view, they are very effective medications. So this is number one. And you can see it very nicely in this slide. Insulin can drop A1C any number, as you can see, from 1.5 to 3.5. And then if you look to lifestyle, sulfonylurea and metformin can drop between 1 and 2% the A1C. The other medications are weaker, and GLP-1 can drop to up to 1.5%. But lifestyle, sulfonylurea, metformin, and then insulin are the most potent medication. Sulfonylurea remains the most effective medication when you add it to metformin. Added to metformin, there is no evidence when you add sulfonylurea that you exhaust the beta cell. This is a very misleading concept that you give sulfonylurea, you exhaust beta. That is not true. There is no data to show that this is a big myth that sulfonylurea exhausts beta cells. In reality, when you get diabetes control under very good control, beta cell function in much better way because glucose toxicity is gone. So if you improve glucose toxicity, you will have efficient medication. There is no evidence that it is less safe than any other medication. There is no evidence, and I will show you regarding safety. But there is evidence that it is very effective. I told you from 1.5 to 2%. They are cheap medication. They are well-tolerated medication. So when you evaluate any medication in general, you need to evaluate efficacy, tolerability, safety, cardiovascular safety, durability for if the medication is working for longer duration, and then cost. And actually, every aspect of this is met in sulfonylurea. So efficacy, if you add sulfonylurea or start with sulfonylurea, this is for people who never been on any medication. You will get A1C drop around 1.5%. This is from big meta-analysis of 9 studies, used medication for 16 weeks at least, and for baseline between 6.5 and 13. So you give it as first medication, you get A1C of 1.5%. If you add it to metformin, you get an additional 1.6% drop in A1C. Again, this from 4 big studies and added to metformin or TZDs in people with higher A1C. So whether you give it as monotherapy or you get added to metformin, you will get significant drop in A1C. So it is very effective medication. What about tolerability of the medication? In tolerability of the medication is very important because you don't need medication that cause significant risk. And what inherited in the mind of all people is that sulfonylurea cause severe hypoglycemia and sulfonylurea cause weight gain. So what is the reality? And actually, most studies showed no difference in the total number of adverse events. There is increase in hypoglycemia, but only mild and moderate. No severe hypoglycemia. People think that it causes severe hypoglycemia, but actually most clinical trials showed this is minimal, very minimal, especially if you are using the right dose. And what about weight gain? It is 2.3 kilogram weight gain over 6 years. So it is not like people take sulfonylurea, gain 10, 15 kilograms, they gain 2.3 kilograms. And the reason is very simple. You give sulfonylurea, you stimulate insulin. Insulin is lipogenic hormone, so accumulate fat a little bit and people start to gain weight. And that weight gain is 2.3 kilograms. So we have to put things in perspective in relation to tolerability of the medication. So what about safety? Safety is the side events. And here is a big trial, adopted trial for over 5 years. So if you compare the drug in that study, 28% get some symptoms of hypoglycemia, as I mentioned, mild or moderate, doesn't require any intervention. And only 0.6% over 5 years developed severe hypoglycemia. Can you imagine 0.5? We are talking about hypoglycemia. Hypoglycemia is 0.6%, and this is a very big trial. And if you look to conventional treatment in UKPDS study, 0.7, chlorbromamide, which is a very old medication, sulfonylurea, 1%, glibenclamide, 1.4%. So in reality, severe hypoglycemia is not supported by a lot of studies that sulfonylurea is causing severe hypoglycemia. Yes, mild or moderate hypoglycemia. What about cardiovascular safety? You know, many clinical trials had been done, and the biggest one is UKBDS study. And they found that if you give sulfonylurea, or if you give sulfonylurea-based therapy, and you evaluate the impact of sulfonylurea cardiovascular outcomes, for those studies are long-term studies, more than 72 weeks, 15 trials, and the conclusion, there is no increase in the incidence of cardiovascular disease. Actually, they found that the p-value for benefit is 0.054, which is missed the significant by very little. Over 10 years, there is significant improvement in cardiovascular, which is, again, in the mind of people that it worsens, is actually, it doesn't even increase the incidence of any cardiovascular disease. So why metformin and glimepiride in combination? This is what's called glucovans. Glucovans is combination of the two medication already together. So let me explain first what this glucovans means. Glucovans is a matrix here of metformin and different particle size of glibenclamide. So it could be very small, could be bigger, or way bigger. As you can see, distribution of the particles of sulfonylurea. So what is the difference here? Actually, smaller particles get absorbed very quickly. So you get quick sulfonylurea, intermediate sulfonylurea, and longer acting sulfonylurea. And that's the benefit of having this combination. So for example, if you give metformin and sulfonylurea separate, you will see the efficacy start after 4 hours, and you can see later on, this is the free combination. But if you give glucovans, the combination which I mentioned, you see immediately after you give it, there is immediate effect, as you can see, and lasting for the same duration. So you need earlier and much better efficacy. And that's why if you compare just metformin with glibenclamide separately, you drop A1C by 1.9%. But if you just start with glucovans directly in combination pill, in one combo pill, drop in A1C is 2.9%. So big difference between just adding glibenclamide to metformin or give people just glucovans. What is also important is postprandial. As you can see, the postprandial excretion is much less with the same, exactly the same, 500 milligram and 2.5 milligram. The excretion after meal is significantly up, more than 100 still. Here is much less. So again, this is important. And what if someone has metformin and glibenclamide, and then you add, or you just switch it to glucovans? The reality, adherence is much better. If you take 2 pills per day and instead of taking 1 pill, and the adherence, as you can see, 77%. Don't underestimate the value of the adherence. Adherence in every aspect. Here is, for example, if you switch from free combination to glucovans, you see the adherence is 87%. And why adherence is very important? Every time you have increase in adherence, you see reduction in A1C. In reality, every 10% improvement in adherence reduce A1C by 0.1%. So if people are not taking their medication 50% of time, their A1C is up by 0.5%. If people are taking their medication 80% of time and miss it 20%, their A1C is higher by 0.2. So every 10% increase in adherence drop A1C by 0.1. So you need people with higher adherence, 70%, 80%, 90% taking their medication. Regarding hypoglycemia, as I mentioned, the mild and hypoglycemia around 10-12%. Severe hypoglycemia, here is glucovans 2.5 and here is glucovans 5. You can see very small percentage, between 0 and 2%. People achieve the target much better. As you can see, 56% get A1C lower than 7. And this, if you compare it to DPP-4 inhibitors, only 36% get to the target. So what are the supporting evidence that we have? There are many supporting evidence for combination. So if you start your patients from get-go, monotherapy, on metformin, you get 1% drop. If you give sulfonylurea, you get 1.2% drop. If you give glucovans, you get 1.5%. So if you start your patient directly on the medication, you get 1.5%. I told you that before. So it's better than giving either of the medication alone. Now, if you add it to metformin, so if you keep metformin, you will not get any additional benefit. If you switch metformin to glibenclamide, you may get 0.3% drop. But if you add immediately metformin to sulfonylurea, you get another 1.2% drop, additional drop in A1C. So whether you give it as monotherapy or you switch from metformin, you will get a big drop in A1C. What about sulfonylurea? If you keep the sulfonylurea, you get whatever you get. If you switch it to metformin, you will not see also any improvement. But if you add now the combination, you will get between 1.7 to 1.9 additional drop in A1C. So switching from metformin or switching from sulfonylurea or start de novo, you get very good efficacy. Durability, the drug is actually working for longer duration and the same efficacy. Here is one entire year, and there is a adopted trial with 3 years, and the medication is still working in a very efficient way. What about cost? And here is in patient who switch it from gliclazide to metformin and to metformin or to glucovans. And as you can see, there is a significant drop in A1C, additional drop in A1C, almost 0.9% drop in A1C, which is very impressive. And if the A1C is initially high, the drop in A1C is 1.3, and the cost is lower by 45%. So again, data is showing that it is less costly, and you can get very, very nice drop when you switch from gliclazide. So now, take to practice message. Sulfonylurea are particularly effective in certain cluster of patients: severe insulin deficiency diabetes, severe insulin-resistant diabetes, and mild age-related diabetes. This is 40%. This is 15%. So 55%. This 60%. There is now 61% can respond to the medication. In addition to metformin, sulfonylurea are effective. They are cheap. They are safe. Second-line therapy. Severe hypoglycemia of sulfonylurea is very rare. I showed you that. Pre-combined metformin and glibenclamide in one pill, glucovans, improve absorption of sulfonylurea, reduce postprandial. I told you the excretion is much less. A1C is better, and adherence is much better because this is less medication. And then starting uncontrolled the patient on pre-combined metformin, glibenclamide can reduce A1C by 2.5% in comparison to 1.5%, by 1.9% if you just add them together. With this, I would like to thank you so much for your good listening, and I wish you a wonderful, wonderful, great symposium. Thank you very much. And I will be more than happy to entertain any questions that you have.
Thank you, Dr. Osama. The floor is open for any questions. Dr. Khalid.
Thank you very much for this. My question regarding the vision or the reverse of type 2 diabetes. Sometimes patients come to the clinic and ask you, can I take this medication of my life?
I cannot hear you very well. I don't know, the mic has an issue or...
Doctor, thank you very much.
Yeah, that mic is much better, yes.
Okay. My question to you regarding the patient come to your clinic and ask you when you have type 2 diabetes regarding, can my diabetic by reverse? Shall I stop my medication? What can you tell him?
It depends. You know, we have a program at Joslin Diabetes Center right now. It's called Diabetes Remission Outcome Program. And we found in Diabetes Remission Outcome Program, if people are diagnosed with diabetes, especially mild obesity diabetes, in the first early 5 years, with very good amount of weight loss, people can stop all their medication. I told you, mild obesity diabetes is related to obesity. If you take obesity out of the door, diabetes will go out of the window. But you cannot apply this to someone who is lean with severe insulin deficiency diabetes. They will not lose weight. You don't need them to lose weight. They already with lower BMI and their A1C is high. And their problem is beta cell dysfunction. You need to stimulate their beta cell. You have people who antibodies are positive. Those are people treated with insulin. You have people who are old, and all what they have is mild beta cell dysfunction. You just give them sulfonylureas or DPP4 inhibitor. So you need to build your own judgment about which case and what treatment that you will do. But some people can get remission from diabetes or reversal of diabetes. This is a mild obese diabetes. Some people will get improvement in their diabetes quickly and very long time, like age-related diabetes. Some people will give you very hard time who are severe insulin resistant. They can be on 3 or 4 or even 5 medication and insulin in a very large dose without good control. That's why moving in a precision medicine and instead of putting all type 2 all diabetes in one basket and say type 1 and type 2 didn't help us for very long time. We have people even their diabetes improved, but they continue to develop complications. Like for example, severe insulin deficiency diabetes. Even if you control them, an A1C in good range, they still continue to develop diabetic retinopathy. Severe insulin resistant diabetes, even with good improvement, they will still develop and progress into end-stage renal disease. So I think that all the classification is a problem and didn't help us. And let us move to the future together. And clinically, we can do that by lab, and maybe genetics in the future can tell us even better.
Thank you very much. Thank you.
Thank you, Dr. Osama. يعني وكأنك أعدت الاعتبار للسلفونيليوريا اللي هي the most popular in our country and the cheapest.
And still very effective يا دكتور زي يعني
still very
effective. يعني أنا حبيت أوضح الدروباكس اللي بتحصل مع GLP-1 والاس جي ال 2 واللي لازم نكون فاهمين كل دراج in their perspective. So I hope the message is already there, and إن شاء الله لما نيجي عندكم في اليمن نتناقش أكتر ونناقش حالات ونشوف قد إيه نقدر نعمل لها. أنا سعيد جدا بكم وألف ألف شكر.
شكرا كثيرا. في سؤال يا شباب؟ Thank you دكتور أسامة.
الله يخليك، سألك يومكم جميل إن شاء الله، مع ألف ألف سلامة.